I've opened more than 2,000 human chests in my career. I've held beating hearts in my hands, felt them pulse, struggle, fight. And when you've done that long enough, you start to notice something most people never will. There's a difference between a heart that's strong and one that's quietly losing the battle. Not dramatically, not suddenly, silently. For years, I believed the biggest threats to the heart were obvious: poor diet, smoking, genetics. And yes, those matter. But some of the worst damage I've seen on the operating table didn't come from any of those. It came from something far more unexpected: medications. Pills prescribed with the best intentions that were slowly working against the heart instead. I'm Dr. Kevin Adewale, a cardiothoracic surgeon. For over 25 years, I've operated on hearts that reached the point where surgery was the only option left. And today, I want to talk about 5 specific medications taken every single day by millions of people over 60 that almost never get fully discussed in a standard appointment. This isn't about fear, it's about clarity. Because after 60, your body doesn't process medications the same way it used to. Your kidneys filter more slowly. Your liver metabolizes drugs at a reduced rate. And most importantly, medications don't exist in isolation anymore. The average person over 65 takes 4 to 5 prescription drugs daily. Many take more. Each one tested individually, approved individually. But what happens when you combine them inside a body that's already working harder just to maintain balance? That question rarely gets answered. Let me introduce you to someone I'll call Clarence. He's 74, a retired electrician, sharp, disciplined, the kind of man who did everything right. He walked 2 miles every morning. He watched what he ate. He followed every instruction his doctors gave him. On paper, he had every reason to believe his health was under control. But when he came to see me, that wasn't the reality. He had just experienced his second cardiac event in less than 2 years. And what struck me wasn't just his condition, it was how he described what he was feeling. Not tired, exhausted. The kind of exhaustion that settles deep into your bones. The kind that doesn't go away after sleep. Muscle cramps waking him at 3 a.m. His thinking had slowed in ways that genuinely scared him. He had seen 3 different doctors, and every time, he got the same answer. You're 74. This is normal. He lived like that for 2 years. When I sat down and reviewed his full medication list, every drug, every dose, I didn't need long. Within 5 minutes, the problem was clear. Not one issue. 3, all happening at the same time. For 2 years straight. We'll come back to Clarence, because how his story ends is exactly why this conversation matters. Now let's start with the first medication, one of the most commonly prescribed drugs in the world. Statins. If you're over 65, there's a strong chance you're taking one right now. The names vary: atorvastatin, rosuvastatin, simvastatin, but the mechanism is the same. And let me be clear, statins save lives. For people with established heart disease, the evidence is strong. I've prescribed them thousands of times, and I stand by that decision. But there's something buried deeper in the biology that almost never gets explained. Statins block a pathway in the body responsible for producing cholesterol. But that pathway doesn't just make cholesterol. It also produces something else, something your heart depends on every second of your life: CoQ10. And that detail changes everything. Because CoQ10 isn't optional. It's fuel, the energy source your heart cells rely on to function properly. Like oil in an engine, without it, things don't stop immediately. They wear down, slowly, quietly, and over time, that wear becomes impossible to ignore. What happens next, and how this single mechanism affected Clarence for 2 full years, is something most people are never told. And once you see it, you won't look at these medications the same way again. CoQ10 is not some optional nutrient your body can afford to lose. It is essential. Every heartbeat, every contraction, every ounce of energy your heart produces depends on it. Inside your cells, CoQ10 works like a spark plug, driving the production of energy at the most fundamental level. Without it, your heart doesn't stop. It weakens, gradually, and that's where the problem begins. Because when statins block the mevalonate pathway, the same pathway responsible for producing cholesterol, they also reduce the body's natural production of CoQ10. Not slightly, significantly. Multiple studies, including large meta-analyses, have shown that statins can reduce CoQ10 levels in the blood by 30 to 50%. Think about that for a moment. A 30 to 50% drop in the very compound your heart relies on for energy in people who are already taking the medication to protect their heart. That contradiction is rarely explained in a typical appointment. What does that look like in a real person? It doesn't show up as a dramatic emergency. It shows up quietly. Fatigue that doesn't improve with rest. Muscles that feel weaker than they used to. A kind of mental fog that's hard to describe but impossible to ignore once it sets in. And in some patients, something more measurable, reduced cardiac efficiency. The heart is still beating, still doing its job, just not as well as it could. Now, go back to Clarence. He had been on a high-dose statin for 2 years. 2 years of his heart functioning below its optimal capacity. 2 years of unexplained exhaustion. And here's the part that should make you stop and think. No one had checked his CoQ10 levels. Not once. Because it's not standard practice. It's not part of routine guidelines. In many cases, it's not even covered by insurance. Why? Because CoQ10 isn't a patented drug. It's available over the counter. There's no financial incentive built into the system to prioritize it. This isn't about conspiracy. It's about what the system naturally rewards and what it quietly overlooks. Now, does this mean statins are harmful? No. It means the conversation around them is incomplete. Because if a medication lowers something your body needs, the logical next step is simple. Do we replace it? In many cases, the answer is yes. Supplementing with CoQ10, typically in the range of 100 to 200 milligrams per day, has been shown to improve symptoms in certain patients, particularly those experiencing fatigue or muscle-related side effects. There's even clinical evidence, like the Q-Symbio trial, showing improved outcomes in heart failure patients who supplemented with CoQ10 alongside standard therapy. But here's the key. This is not about stopping your statin. It's about asking a better question. Should I be supporting my body while taking this medication? That single question can change the entire trajectory of how your treatment works, and it's one most people never think to ask. Now, let's move to the second medication, because this one is even more deceptive. It doesn't look like a heart drug. It's not prescribed by a cardiologist. In fact, you can buy it almost anywhere, no prescription required. Most people take it without a second thought. Ibuprofen, naproxen, diclofenac, the NSAIDs. They sit in medicine cabinets across the world, taken for headaches, joint pain, back pain, everyday discomforts that seem completely unrelated to the heart. And that's exactly what makes them dangerous. Because the assumption is simple. They reduce inflammation. Inflammation is bad for the heart, so they must be safe, maybe even helpful. But that logic is not just wrong, it's backwards. Because what these medications do inside your body, specifically inside your blood vessels, tells a very different story. A story that most people never hear. And once you understand it, you'll never look at a simple painkiller the same way again. Here's what most people don't realize about NSAIDs. Yes, they reduce pain. Yes, they lower inflammation. But the way they do it comes with a trade-off, one that directly affects your cardiovascular system. NSAIDs work by blocking enzymes in your body, called COX enzymes. There are 2 main types, COX-1 and COX-2. And while that might sound technical, the consequence is very simple. COX-2 produces something called prostacyclin. Think of prostacyclin as your blood vessel's natural defense system. It keeps them relaxed, flexible, and open. It prevents unnecessary clotting. It maintains balance. Now here's the problem. When you block COX-2, you reduce prostacyclin. And when prostacyclin drops, that protection disappears. Your blood vessels become more prone to constriction, more prone to clot formation, less adaptable to stress. At the exact same time, regular NSAID use has been shown to raise blood pressure on average by 3 to 5 millimeters Hg. Now that number might not sound alarming, but after the age of 60, when your arteries are already less elastic, even a small increase in blood pressure matters. Because it's not just about today, it's about accumulation. That extra pressure, sustained over months and years, increases the risk of stroke and heart attack in ways that build slowly and then show up all at once. This isn't theoretical. In 2015, the FDA placed a black box warning on NSAIDs. Not just for stomach bleeding, which many people already know about, but specifically for increased risk of heart attack and stroke. It's written clearly on the label. And yet, Most people taking these medications every day have never had that conversation. Now, think about Clarence again. For 2 years, he had been taking ibuprofen daily, every single day. His doctor knew, but no one connected it to his heart. No one stepped back and asked what this combination of medications was doing over time. Because individually, each decision made sense. But together, they told a very different story. Now, this doesn't mean you should never take NSAIDs. It means the way you use them matters. If you're dealing with chronic joint pain, there are alternatives that reduce systemic exposure. Topical NSAIDs gels, applied directly to the skin, can deliver anti-inflammatory effects exactly where needed, with up to 90% less absorption into the bloodstream. Same benefit, far less impact on the rest of your body. For underlying inflammation, there are compounds with growing evidence behind them. Curcumin, especially when paired with piperine for absorption, has shown measurable anti-inflammatory effects. Omega-3 fatty acids, EPA and DHA, have even stronger cardiovascular data. In large trials, higher doses have been associated with up to a 25% reduction in major cardiovascular events. That's not a small number. That's significant. But again, this isn't about replacing one pill with another on your own. It's about asking the right question. Is there a safer long-term strategy for managing this? Because long-term is where the risk lives. And that brings us to the third medication. This one is even more subtle, because it doesn't feel like a risk at all. In fact, it feels like relief. People take it in the morning with their coffee, sometimes for years, sometimes for decades, and they rarely think about it twice. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, medications designed to reduce stomach acid, and at first glance, they seem harmless. After all, they're just treating acid reflux, right? But what if the acid they're suppressing isn't the problem? What if it's actually part of the solution? Because your stomach acid isn't just there to cause discomfort. It has a job, a critical one. And when you shut it down long term, you don't just remove the symptom. You disrupt a system your body depends on, a system that connects directly to your brain, your nerves, and your heart. What happens next is one of the most overlooked chains of cause and effect in modern medicine, and it's something almost no one explains until it's already been happening for years. Your stomach acid is not your enemy. It's a gatekeeper. It breaks down food, activates enzymes, and most importantly, allows your body to absorb critical nutrients. Without it, entire systems begin to falter in ways that are easy to miss, until they're impossible to ignore. This is where proton pump inhibitors, or PPIs, quietly change the equation. Medications like omeprazole, pantoprazole, and lansoprazole are designed to suppress stomach acid. And for short-term use, they can be incredibly effective. They relieve symptoms, heal irritation, and give people real comfort. But the problem isn't short-term use. It's what happens when that use becomes long-term, and no one reevaluates it. Because when you suppress stomach acid continuously, you don't just reduce discomfort. You block absorption. One of the first nutrients affected is vitamin B12. B12 requires stomach acid to be properly released from food and absorbed into your bloodstream. Without sufficient acid, that process breaks down almost completely. Now here's why that matters more than most people realize. Vitamin B12 is essential for maintaining your nervous system and producing red blood cells. But from a cardiac perspective, it plays another critical role. It helps regulate homocysteine. Homocysteine is an amino acid that, when elevated, directly damages the inner lining of your arteries. It promotes inflammation, accelerates plaque formation, and increases the risk of cardiovascular events. In some studies, elevated homocysteine has been shown to be as significant a risk factor as high cholesterol, and yet, it's rarely tested. So now you have a situation where a medication taken for acid reflux is indirectly contributing to vascular damage through a pathway most patients have never even heard of. And it doesn't stop there. PPIs also interfere with magnesium absorption. Magnesium is involved in over 300 enzymatic processes in the body. But for your heart, its role is especially critical. It helps regulate electrical activity. It keeps your heartbeat stable and coordinated. When magnesium levels drop, the risk of arrhythmias increases. Muscle cramps become more common. Sleep becomes more fragmented. That 3 a.m. cramp that wakes you up, that's not random. That's a signal. Now, go back to Clarence. His B12 levels came back critically low. His magnesium levels were technically within the normal range, but at the very bottom. And that's another issue. Normal doesn't always mean optimal. It just means you haven't crossed a threshold that triggers intervention, but the body feels the difference long before the lab report flags it. Clarence had been on a PPI for years. No one had checked his B12 annually. No one had questioned whether he still needed the medication. And slowly, quietly, deficiencies had developed layer by layer until they started showing up as symptoms no one could fully explain. Fatigue, brain fog, muscle cramps. Sound familiar? Now, what can be done? First, awareness. If you're on a long-term PPI, testing matters. Ask for your B12 levels. Ask for magnesium. Second, strategy. If B12 is low, one of the most effective ways to restore it is through sublingual supplementation, methylcobalamin, taken under the tongue. This bypasses the need for stomach acid entirely. For magnesium, forms like magnesium glycinate or citrate are far better absorbed than the oxide versions commonly found in inexpensive supplements. But here's something critical. You should not stop a PPI abruptly, because when you do, your body often responds with a rebound effect. Acid production surges back stronger than before, symptoms worsen, and most people go right back on the medication. The right approach is gradual, a structured taper guided by your physician, because the goal isn't to eliminate the medication blindly. It's to understand whether it's still necessary and how to support your body if it is. Now take a step back and look at the pattern. A statin, reducing CoQ10. An NSAID, removing vascular protection. A PPI, blocking essential nutrients. 3 different medications, 3 different mechanisms, all affecting the heart in ways that are rarely discussed together. And, in Clarence's case, all 3 were happening at the same time, for 2 years. And we're not done yet, because the next 2 medications are where even experienced physicians, including myself, have had blind spots. The 4th involves a drug that prevents clots, while accelerating something I've seen with my own eyes in the operating room. And the 5th, that one forced me to question years of my own recommendations. What I discovered changed how I practice medicine, and it's not an easy conversation. Pill 4 is one of the most trusted medications in modern medicine, warfarin. For decades, it has been prescribed to prevent dangerous blood clots, especially in conditions like atrial fibrillation. And it works. It saves lives. I've relied on it myself in countless cases. But here's what often goes unspoken. Warfarin works by blocking vitamin K. And while that helps prevent clot formation, it also interferes with something equally important, vitamin K2. K2 has one critical job. It directs calcium out of your arteries and into your bones, where it belongs. Without it, calcium doesn't disappear. It drifts. And over time, it begins to settle into your arterial walls, making them stiff, narrow, and calcified. I've seen those arteries firsthand in surgery. They're harder to work with, harder to repair, and far more dangerous over the long term. This doesn't mean warfarin is wrong for you. It means the conversation is incomplete without understanding what it takes away. Ask your doctor, is this still the best option for me today? And most importantly, don't wait for symptoms to ask better questions, because what you don't ask today, your body may answer later.